Hi, I'm Dr. Trevor. Today I'm going to talk about the challenges of working in lower middle income countries. So as you can see on the photo, this was the biggest challenge I faced in Nixon Hospital in the past 5 months. So we were doing an emergency operation to perform cesarean section because the baby was having fetal distress and the pregnant woman turns out to be uterine rupture. So soon after the baby was delivered, the electricity went off. So we were forced to continue the operation with only a torchlight. So this was really ridiculous. So why am I sharing my experience today? So because I took the DKMH course uh, this year in February. So I was in the spring batch. So after that, I tried to apply MSF and Doctors with Africa. However, they didn't accept my application. But luckily, um, Chris shared this experience with me, and then I applied it successfully. So I was volunteering in Nixon Hospital in Sierra Leone, which is in West Africa. So as you can see, the capital is Freetown. So our hospital is in Sheboygan, which is like 7 hours journey from the capital Freetown. And this was the outlook of our hospital. So why am I sharing my experience? Is because we want to find the next Pumui. So the Pumui is in local language Mende. Pumui means white man, but also Lulele. Lulele is black man. So we want to recruit more doctors to come. So in Nixon Hospital, we have 5 wards. So men's medical, surgical, females ward, children's ward, and maternity ward. And this is how it looks like in the ward. So in men's medical ward, we have 18 beds. So the most common disease is typhoid. So first of all, how do we diagnose typhoid? So there are two types of methods to diagnose typhoid. The first type is serodiagnosis, which is use reader test, but more than 90% of the patients are test positive. So this reader test actually lacks sensitivity and specificity and is not recommended by WHO. And then the second method is culture. However, because culture is not available in our hospital, so turns out everybody tests positive for reader test. So which means like everyone is having typhoid. But what if we treat all the patients with the antibiotic and then the resistance develop? But luckily, no resistance is detected in our hospital because culture is not available. So other than typhoid, we also have hepatitis crisis, heart failure, pneumonia, tuberculosis, cirrhosis, acute gastroenteritis, peptic ulcer bleeding, soil-transmitted ailments, schistosomiasis, HIV, and snake bite. So I want to draw your attention to HIV because you know that HIV is very important in tropical medicine, and actually it's true that we are facing stigma for HIV. So even when the medical staff talk about the test, we will say it's let's do the RVS test, retrovirus test, or the 3 letters test. So according to WHO, uh, when you diagnose a patient with HIV, if the prevalence is very low, so you need to do 3 sequential tests. However, because of limited resources, we were only able to do 2 sequential tests, which means do the test for 2 times. And we also don't have any CD4 count. We only use a rapid test, which is called BCTEC CD4 advanced disease to tell whether the CD4 count is lower than 200. and we cannot test for the viral load. Obviously, we cannot test for gene expert, we cannot test for urine lamp and cryptococcus antigen. And the only medication we have in our hospital is tenofovir, lamivudine, dolutegravir. So if the patient is having kidney impairment or chronic kidney disease, there's no other medication. But luckily, no kidney impairment is detected in our hospital because we couldn't test for the renal function. So let's move on to the main surgical ward. We have 15 beds. The common disease are inguinal hernia, road traffic accident, skin and soft tissue infection, acute urinary retention, and dental abscess. So before coming to Sierra Leone, I've never seen dental abscess before. And then all of them, because they couldn't afford to go to the nearer city to see a dentist, so all the tooth decay was left untreated until developed a very serious infection called dental abscess and even deep neck infection. And these are the horrible photos. So I think most of the people know about the secret, the law of attraction. So if you want something, all you have to do is direct your request to the universe, and then the universe will inevitably respond to your request if you ask for it. So because dental abscess is so serious, and most of the patients they are like 30 years old man who is the financial support of the family. So after a patient pass away, because the mortality rate of dental abscess in Sierra Leone is about 46%, which is crazy high. So after the patient passed away, the whole family collapsed. So as we were saying about the law of attraction, I posted this voluntary opportunity in the Facebook group, and then one doctor replied me, and then she suggests this NGO to me, which is called Oral Healthcare Africa Initiative. So even though I have written an email to them in end of July, they didn't reply me until I sent them a message on Instagram. So after that, we had a meeting, and then we developed a training handbook for the dental procedure, and then we invited them to come to Sierra Leone to teach our medical staff, to teach our nurses how to perform simple, basic dental procedure like scaling, like remove retained roots, and remove tooth decay. So other than dental abscess, in Africa you can always see a very serious skin and soft tissue infection. So on the left side you can see, so initially it was a small boy, small swelling, but then they went to the traditional healer, they used the hot drop and make the infection worse. So in the right side you can see that it's a very serious shingles. So it looks super crazy painful. So let's move on to the females ward. In females ward, medical and surgical ward they are combined together, which is about 20 beds. So other than the common disease we saw in the males ward, you can also see that pelvic inflammatory disease and umbilical hernia is also common in females ward. So let's talk about the tuberculosis. As you also know that, so tuberculosis is very common in patients who is living with HIV. So in Sierra there's also stigma. So if the patient is diagnosed with tuberculosis, So there will be stigma that, oh, this patient also have HIV. And unfortunately, we only have sputum and acifastin in our hospital. So we don't have gene expert. So we don't have PCR to help us detect tuberculosis. And the contact tracing and prophylaxis are inadequate in our hospital. So because in our hospital we don't have X-ray, we only have ultrasound. So this is the ultrasound finding of a patient. So you can see that the hypoechoic fluid, which is pleural effusion, and you can also see there's collapsed lung due to the lung hepatization. And you can also see that there's something out coming out from the lung to the pleural effusion. So this patient, we send them to the other hospital for X-ray, and then you can see the X-ray. There's the evidence of pneumothorax and pleural effusion. So it's hydropneumothorax, which is a serious complication of tuberculosis. But we know that other than pulmonary tuberculosis, extrapulmonary tuberculosis is even more difficult to be diagnosed, because in our hospital we don't have pathology and there's no culture, so we cannot diagnose extrapulmonary tuberculosis in our hospital. So in the lecture we also learn about the focus assessment with sonography for HIV associated tuberculosis. And however, HIV associated tuberculosis is not common here. So what if the HIV is negative? How should we diagnose the extrapulmonary tuberculosis? So should we consider empirical treatment for suspect extrapulmonary tuberculosis? So as you can see, this is a very cute child, but the problem is you can see that there's left lower jaw swelling. So there was a lymph node and it's hard to touch. There's local heat and local swelling. So we suspect this patient was having extrapulmonary tuberculosis. We gave empirical treatment for the extrapulmonary tuberculosis, and then as you can see that the swelling improved after a few months, after 1 month of the treatment. So when should we consider empirical treatment for extrapulmonary tuberculosis without any evidence? Maybe during a patient with unexplained prolonged fever, or unexplained lymph node enlargement, or unexplained abdominal distension. So we also know that uh, there are a lot of factors that will determine your health, and there's also a thing called social determinants of health, which means like your age, your sex will also contribute, will affect your health, and also of course your education, work environment, living and working conditions. So, but the biggest problem in a Shebima in our hospital is the sex, because most of the women, they are financial dependent, so they only come to our hospital when the husband is back. So they only come they only come at night or on Sunday. So these are the most vulnerable session timing in our hospital, because there are limited staff and the system doesn't work very well during at night and on Sunday. So we all know that in fertile women with lower abdominal pain, you always need to rule out ectopic pregnancy. So which leads us to the maternity ward. In maternity ward we have 16 beds. The common diseases are ectopic pregnancy, placenta abrasion, placenta previa, uterine rupture, retained placenta, septic abortion, and disease of newborn. And the problem we face here is when we have a patient with obstructed labor, maybe you need to consider TB or Armstrong vacuum, but we don't have it here. So there was even one case who leads to stillbirth because of no TB vacuum. So preeclampsia and eclampsia are also common, but sometimes we don't have magnesium sulfate. So we all very familiar with the 3 delay models. So the first delay is the delay in recognizing a need to seek care, and then the second delay is delay in reaching the medical facilities, and then the third delay is delay in receiving care at facilities. What can we do about it? So first you need to understand why is there a delay. So the first delay is delay in recognizing a need to see the care, because most of the patients, they are afraid of the hospital, they are afraid of losing the baby, and this is how they define the relationship in the villages, is because you need a baby to build a relationship. So if your husband pass away and you need to find the others to help you to take care of your children, so you need to give birth to that person so that you all can have a relationship. So the other reason is the patient was withheld by the traditional birth attendants, and also lack of awareness and few ANC antenatal clinic visit. And then the second delay is delay in reaching the facility. So in Shabima, we don't have any car, so only motorbikes are widely available, and it's long distance from the village to the hospital, and the road is not safe, especially during the rainy season, and also the delay referral. So this now you can see that the green star is our hospital, and then the yellow star are all the peripheral health units. So the patients, they will go to the peripheral health unit, then referred by the peripheral health unit to our hospital, which is a very long distance. When the road is not safe, muddy, especially during the rainy season, on the motorbike, it's very scary and very unsafe. And then the third delay is delay in receiving care at medical facility, because it's very easy to blame the patients to be late to show up at the hospital, and but also the medical staff, they have no sense of urgency, maybe under training, and sometimes even poor phone signal, you couldn't call the doctor to come, and then there's no blood bank, so you have to collect the blood transfusion before the surgery, which is causing the delay, and the instruments, the surgical instruments are not pre-sterilized. So in the nutshell, we learned about the solution for delays. Maybe to build a maternity waiting homes, improve transportation, patient education, empowerment of women, improve staff training, infrastructure, procurement. But actually how? So every time when we face a patient with suspect ectopic pregnancy, it's almost a mission impossible. So in a fertile woman with amenorrhea and lower abdominal pain, the first you need to call the lab team to come to do the pregnancy test, hemoglobin, blood group and cross matching, and you also need to buy a blood donor, prepare the blood. And the second thing is you need to get ultrasound for diagnosis. You need to get 2 different keys to get into the ultrasound room to perform the ultrasound. And then the third mission is to get the operation team to prepare the fluorescent instrument, get sutures, cotton wool and gauze. So the median preparation time for the patient to receive an emergency operation for ectopic pregnancy is about 2 hours, which should be medical emergency. But sometimes it's very difficult because in Sierra Leone, pregnant woman is under free health. So which means even if you come to do an emergency operation in the midnight, you still get nothing because the operation itself is free. Very sad and discouraging. So in our hospital, we also perform ultrasound scanning. So in the left side, you can see this is the ultrasound for fetus, which show hydrocephalus, which leads us to the children's ward. So in children's ward, we have malaria, convulsion, diarrhea, pneumonia, severe acute malnutrition, and neglected. So in Shibima, they use soap. Uh, they use soap to wash their clothes. Problem is, they some of them will put the soap into a water bottle that looks like Coca-Cola, and then the child accidentally drink it, which cause the esophageal stricture in the future. So another very sad story is because it's very difficult for them to collect water. So in the rainy season, they usually use a big bucket to collect the water. But the problem is they don't have the cover, so they didn't cover the bucket, and then left uh, they left their children, and then the baby accidentally drowned into the water bucket because there was no water. But I want to focus on malaria and severe acute malnutrition. So let's talk about malnutrition first. So before we came, they did not screen routinely by using the mid upper arm circumference and weight height Z score, and there's no pumping nut. And there's also no F75, F100 milk, and most of the patients they don't have money to buy food. Luckily, Friends of Nissan, our NGO, built a feeding program for the malnutrition patients. So we know that F75 and F100 milk, they are important for the treatment of severe acute malnutrition. So if you don't have the proper F75, F100 milk, what can you do? So in limited resource setting, you always need to improvise. So if you don't have the proper milk, you need to use alternative milk ingredients regimens to make the F75 by using uh, skim milk or dry whole milk. And about the malaria, so the biggest problem is we don't have any artesunate and artemeter in our hospital. So when the patient came in with severe malaria, we need to ask the patients to go to the town to buy the artesunate and then come back so that the patients can get medication, which is just ridiculous. So there are a lot of challenges of working in low middle income country. So the first of them is the delay of presentation, delay in seeking care, reaching health facility, and then there's also language barrier, and the patients couldn't afford the tests and medications with limited diagnostic tools and unreliable lab results. Sometimes the medicines are not available and the supply of medication is not stable. So there was one time that we don't have any injection antibiotics in the whole hospitals, and then need to ask the patients to go to the town to buy the antibiotic to come back, which just doesn't make sense. And then the pharmacy is not open at night. And then sometimes the workers they didn't show up for work, and then the lack of sense of urgency, undertrained, and nurses not giving the medications, not signing the drug chart, and there's also lack of blood and unstable power. So when the electricity went off, the blood in the blood bank failed and spoiled, and the vaccine also spoiled. So these are the lab tests in our hospital. So as you can see, there are no liver and renal function tests, and there are no electrolytes. So after my sharing, are you ready to volunteer in low middle income countries? So what makes you a successful volunteer? According to the International Medical Volunteers Association, you need to be organized, well prepared, and have a supportive family, and emotionally stable, have a good sense of humor, a good listener, patient, cooperative, and flexible, and adaptable, able to tolerate some degree of personal discomfort, learn to improvise, and then committed to sharing your knowledge and skills. So these are the 10 advices for working in low middle income countries. So the first is talk to the previous volunteers, get support from NGO, and then get insurance, vaccines, medications, find local guidelines, talk to locals, maybe buy a drinks or meal, maybe bring some gifts, and try to learn the local languages. And beware of the moral injury because you will feel that, oh, if this patient is born in another country, we will be able to save the patient. But because they are born, they are here in the low resource setting, it's very difficult to save them. And it's important for you to share your feelings, cherish the small victories, relax and make your life easier by exercising, reading novels, watching Netflix, listening to music, and have a break. So it's important if you it's easier if you lower your expectations and try to be friend with everyone. Don't get into politics. And it's important to be flexible, trying to find alternative. So bad option is not perfect, but it's still better than nothing, especially when there's no money. So you need to learn how to improvise or not to compromise by using alternative milk reachment when there's no F75 and there's no F100. And try to avoid corruption by providing service instead of money. Try to create a nudge and try to find mutual benefits, mm, and apply some terms and conditions. Try to think of the possible consequences before start doing anything. And be careful of the emotional outbreak. Try to engage the community and try to stay a little bit longer if possible. So don't doubt, I'm here to recruit. So if you still want to come, you are the one we are looking for. So please contact our chairman, Robert Burney, by using this email. So I also try to search some volunteering opportunity on Facebook, and these are the other opportunity of volunteering in low middle income countries. So try to enjoy the course like Chris. And you can see that so after the exam we got the result after 44 days, and as you can see I only got 55 in the public health paper, but I still managed to pass the test. So these are the textbook I suggest you all to read about, and then these are the guidelines. So if you have any question, don't hesitate, please ask me. So these are my Facebook, Gmail, and WhatsApp. This is my number and QR code, and please ask me. Thank you.